Dear colleagues, I am delighted to invite here the world-leading forensic pathologist, Mr. Christophera Milroy. Professor Milroy is a full professor in the University of Ottawa. He qualified in medicine from the University of Liverpool and started training in pathology 40 years ago. He is the fellow of the Royal College of Pathologists and the Royal College of Physicians of Canada. His current research interests includes, among others, metabolic autopsy and the history of forensic medicine. He was made an officer of the Order of the British Empire in 2023. Chris, the floor is yours.
Thank you very much. It's such an honor to be here. I've just come up from Budapest, where bizarrely the British Association of Forensic Medicine decided to have their annual summer meeting. I was asked to explain my post-nominal, so just to say the OBE is the award from King Charles. I'm very honored to have received it. The MD, I think, speaks for itself. Except it's like a PhD in England. The LLB and LLM are actually two law degrees, Bachelor of Laws, Master of Laws, which I picked up on the way. And then the Royal College of Pathologists is the organisation in the UK that does postgraduate education in pathology. And so to get that, you have to pass an exam. Because I'd passed that, they made me a Fellow of the Royal College of Physicians of Canada, which, along with the Royal College of Surgeons of Canada, they're one organisation, conducts all postgraduate education in Canada. And then the DMJ is a Diploma in Medical Jurisprudence, which is an exam that used to be held for forensic pathology. Medical jurisprudence is an old English term for forensic medicine. So I am going to start, I've got two lectures, and I thought I'd start with this one. So a bit about the pathology of drugs, of abuse that we see, and about what we've been through over the last few years with opioids. And because I'm going to talk about opioids, we have to make a financial declaration. I have acted in fentanyl litigation. Now, I'm going to talk a lot about fentanyl. The fentanyl I'm mostly going to talk about is illegally manufactured. But, of course, fentanyl is also lawfully manufactured for medical use, particularly patches for chronic pain, and that was what this litigation was about. It's a question of whether there was faulty patch development and it was causing deaths or not. And it was in the United States. I haven't done that for a while. So here am I now in Canada. This is called, in Inukshuk, it's in Iqaluit, which is the capital of the Arctic Territory. And there is a vision that people have of Canada that it's always like this, that it's always -25 and it's snow. This last week, we've had temperatures of 35 Celsius in Ottawa. So it does actually get quite warm in the summer. But yes, we do cover the Arctic Circle. I fly up there for courts occasionally, but they usually bring them down. So a little bit about Canada. We are a, excuse me, we are a constitutional monarchy. The head of state is King Charles III, but he is in the context of Canada, he is the King of Canada. You're not the King of England, he's the King of Canada. We have 10 provinces, which are the same as states, and we have 3 territories. The territories are all in the north, I'll show you. We have a population of around 37 million. And Ontario, which is the province I live and work in, has a population of around 14 million. So we are the most populous province in Canada. We have 2 official languages, French and English. We also have indigenous languages. So when I go to give evidence in the Arctic Circle, the trials are typically in Inuktitut, which is the Inuit language, which I do not understand a single word of. Our university in Ottawa is bilingual. So we run a medical education program to get your MD in English and in French. And if you join one, you can't swap over to the other, as I understand it. So we have to, if we prepare lectures in English, they get translated by an official department, and you may not deviate from that so that the courses are said to be the same. We are a common law derived system, which means that our law comes from England and is different to the Napoleonic Code type civil law that you have across continental Europe. So that means that our law is essentially case-based, supplemented by statutes of Parliament. If you go and look for a criminal code in England, you won't find it, although we do have one in Canada. Murder is nowhere defined in statutory law. It's only defined in common law starting in around 1616 with a famous phrase. We have, therefore, because we're common law derived, we have coroner systems. Coroners may be, in Canada, they may be doctors, they may be lawyers, or they may be lay people. And they are the investigators, but coroners are not forensic pathologists. In Ontario, they are doctors, but they're typically family physicians. They may be other specialties. Anyone who is medically qualified can apply to be a coroner. I am a sworn coroner, but I don't typically act. We have 4 medical examiner systems in Canada, which is the same as the medical examiner systems in the United States, which is where the system is headed up by a forensic pathologist. And we have one criminal code across Canada, written in English and in French. And so the trials, you have a right to a trial in English or in French. So if it happens, I mean, and it happens occasionally in Ottawa, we have defendants who want their trial in French, in which case I will be translated from English into French. The slightly odd thing is that everyone, all the court officials will be totally bilingual. And I've had the occasion in which the judge corrected the translator on my English, said, no, that's not what he said. Interestingly enough, if there's a disagreement between the interpretation of something in the criminal code between English and French, it's resolved for the benefit of the defendant. That's our system. The one thing is, non-criminal law is decided by the province, and it's typically common law, so very similar to the law in England, except for in Quebec, that's actually like continental civil law, but not the criminal law. Criminal law is, so this is Canada. This is Ontario. That's the province, so the equivalent of a state. That's Ottawa there. We are the federal capital of Canada, but the capital of Ontario is Toronto. Toronto thinks it's the capital of everything. That's the view of the centre of the universe, as it's known. And so each province has its own system for death investigation. The territories all have coroners. This is Nunavut. There's Greenland over there. I cover this territory. That has 37,000 people. And it is the size of Western Europe, to give you an idea of its geography. Ontario is the size of France and Spain combined. And my system has to provide a death investigation system for all of it. But most of us in Canada live within 160 kilometers of the US border. So where we are, you will see, we are literally 1 hour's drive from upstate New York. And then over here, you've got Maine, Vermont, and so on. And then down here, this is Windsor, you've got Michigan next to it, Detroit, literally next to it, separated by a river. So there is Slovakia projected onto Ontario, just to give you an idea of the size of the place. So you're not much bigger than the area I cover in Eastern Ontario. for the whole of the country. We were settled, Canada has an indigenous population. We recognize 3 indigenous groups. First Nations, which in old terms would be what were considered the North American Indians, and that's sort of not an acceptable term, except that our act legislating for them is still called the Indian Act. We have Inuit, who in the United States would be referred to as Eskimos, but the Inuit don't like the term. They think it's pejorative, and it's derived from a Spanish term. And then we have a group of people who were a mixture of First Nations, typically First Nations females, and Scottish, Irish, and French fur trappers who interbred and produced families that were not acceptable to either community. This is going back several hundred years, who become the métis, French for mixed. And so they have been very prejudiced against, and they have their own communities and status. So that's where we are. But with the this is at the top of Baffin Island. That is a Church of England church, just to illustrate the. So the Anglicans. My father was an Anglican minister. So that Church of England is the Reformed Protestant church in England. And yes, we do have polar bears, but only in the Arctic, apart from zoos. And be alert, in the airport when I went, there was an alert for polar bears and one for syphilis, ironically, because syphilis is on the rise. And yes, polar bears can kill you, but I've only ever done one case, and that's claw marks and tooth marks from a polar bear attack. Much more relevant to us is that we have quite significant health problems for the indigenous population, and for those of you who recognize your pathology, some cavitation lesions, completely obliterated lungs from TB. And so we have a significant TB problem among, especially in the Arctic, but also in others. That this woman collapsed and died from this, literally, not slowly, was in hospital being investigated, went outside for a cigarette and collapsed and died. So there are significant health issues that we have to address there. Now, just to go back, it's probably the last I'm going to talk about the Arctic Circle, because fortunately our opioid crisis has never gotten that far north. Significant alcohol use, concerns about tobacco use because of its health effects, but not, occasionally we encounter cocaine in the north, but not, we haven't had a death from fentanyl yet, and I hope we don't. So I'm just going to talk a bit about deaths from the investigation of drug-related deaths, because it forms a significant proportion of our work, or has done. And when you start looking at someone, and this would apply actually clinically as well as post-mortem in terms of looking, the effects can be due to the type of administration, which we can see on external examination, and then as pathologists on internal examination, we can have direct effects, I'll call them, and then we'll have indirect effects, which I'll come to explain. So often the scene information we get, our coroners go to the scene, they are doctors, they'll go with our police. But unlike in your system, or often in continental European systems where the examining magistrate, the prosecutor, dictates what you do, we in our system, it's the pathologist that decides the extent of the examination, what we want to do, which has, for us, significant advantages. So we'll come on to this about what's the extent of the investigation when you have that degree of evidence at a scene. Fairly typical for us. And you will often see people die in this position, when they are having an opioid overdose, because they pass unconscious and they collapse forward. And you can have a fair bet that this is going to be an opioid death, just from the position of the scene. So on the external examination, we need to look at the skin in its entirety. Look at the nose, look at the mouth. Be careful when you're examining people. I've found drug addicts will secrete their needles and syringes in various places. So my texts tend to do it, but we look in the pockets with forceps first, rather than putting our hands in, because there may be a bare needle. And obviously there's a high rate of hepatitis C infection in people who are intravenous drug misusers. But the typical appearance you see in the injecting is multiple injection sites and bruises of various ages, as you see here. And it can lead to sort of tracking where you've got scarring over the veins. And that was kind of almost more of a classic picture years ago. You will notice the pictures I've shown you mostly are diabetic needles. They're very thin. And they provide for less scarring, although if you're repeatedly injecting, you can get infections. So what you do is you thrombose your blood vessels. And you can see here, this is what we call a MOVAT stain, MOVAT pentachrome, which means you have 5 different stains within the histological preparation, which stain connective tissue, they stain elastic. It's a great stain. Our lab is very good because we have a big cardiovascular. That's better, if you look, yeah. Maybe not for temperature, but, and you can see here, this is the temperature. No, yeah. Recanalized. I just took it as I was interested in the case, I grabbed it. We don't normally do histology, or always histology in the sites. But you can also see if you, at injection sites, you may see, so these are giant cell granulomas, and you can see the foreign material there. Typically, that's from crushed tablets. This is a technique called skin popping. Again, I don't know if you see this, but this is subcutaneous injection of the drug, and they get circular scars as a consequence. Typically, it's cocaine, because it's causing circular necrosis. But we're seeing more of smoking. There's a trend away from injection to smoking. So that's a cannabis leaf, but this is what we call a crack pipe. And we call them crack pipes still, even though they may not be using crack cocaine. They also have these, which are crack pipes again. Very simple glass tubes that they're going to suck up the things. Now, there's a case I actually had in England. You can see there's soot on the nostril, which if you clean the body quickly or even pull clothing, you might miss. And this person was actually smoking heroin. This is a more typical appearance we see now. This is a mushroom plume, or champignon de mousse, we always call it in French, even in England. But in this case, there's actually tablet material. I deliberately put this one in, but typically we don't see the tablet material. You see the mushroom plume, the froth in the nose and mouth. A classic picture in the textbooks is from drowning. But actually, we more often see it in opioid overdoses because they've got pulmonary edema. But you can also see it in epilepsy. So in sudden unexpected death in epilepsy, the seizures give you a neurogenic pulmonary edema, and you can see it in heart failure, probably from a cardiogenic. But if we see this in someone that's been nowhere near water, we're going to be very suspicious that it's opioids. It's typically the opioids that cause this. Now, if you take your cocaine long enough, you can necrose your nasal septum. And I'm going to show you a couple of even more dramatic pictures than that. We don't see it that often, but occasionally we do. That is somebody who has got osteonecrosis from repeated cocaine use. This was a case that my wife, who's also a forensic pathologist, did. So that's a hole straight back through the alveolar bone. Typical of cocaine. But this is a case I did 2 weeks ago. So that is a hole through into the maxillary sinus. And it was present on both sides. And look at the bridge of the nose. It's completely collapsed. It's rare, but it turns up. And so that's chronic cocaine use. And the other thing is that you often get poor dentition in these people. And they will also burn their fingers. We call that crack thumb, because they're insensible to the heat as they are inhaling the drug. So you need to look at the fingers, because you sometimes see burning on the tips of the fingers. That's a very dramatic one. And yeah, they can have erosion of the dental enamel. That was someone in their 20s who was a heavy crack cocaine user. Now, just occasionally, and I've never seen this in Canada, so it's an interesting how phenomena can be local. This is somebody who is injecting into their groin, and they're repeatedly injecting into their groin. Well, why would you do that? Well, because people can't see it. They don't look there. If you go into hospital and your arms are covered in bruises, then they can see that you are a intravenous drug misuser, but you can hide it by injecting into your groin. But if you repeatedly do it, you end up with a sinus tract into your groin. Now, they're not without problems, but as I said, I only saw this I've not seen this in Canada. I've only seen it I only saw it in the UK, and that was among heroin users, typically. But this man presented as a death in custody. So he was in a police station. He'd been arrested for drug offences. He'd hidden his heroin in a wrap in the foreskin of his penis, which the police hadn't searched. So that people, we see that. So some of our drug deaths, we will see drugs secreted. Now, in North America, most men historically have been circumcised, so they couldn't actually do this. The British, it's rare, Europe, it's much less common to have circumcision. But you will often see drugs stored in the rectum and so on. So you have to look quite. But what he'd done is he'd thrombosed his femoral vein from repeated use, and he'd got a massive pulmonary thromboembolism. Now, interestingly enough, in England, they would classify this as dependent use of drugs as a manner. In Canada, we would say this is a natural disease, because it's a natural disease consequence of injecting to get a deep vein thrombosis and pulmonary embolism. We'll talk a little bit more about that, but that's the way we would classify that. And if some say, well, drug is, the corollary would be, if we said these were all accidents because it was not, then we'd have every lung cancer as an accident from smoking, because smoking is no more natural than injecting drugs. And then, of course, if you inject, there's a risk of carrying infection. So this was someone I saw who died in hospital. He was being treated for infective endocarditis. And the commonest reason we see infective endocarditis in Canada is from intravenous drug misuse. When I was a medical student, we were taught it was as a consequence of rheumatic heart disease from past rheumatic heart fever. Not anymore. And so here we have it. It's also said to be more common in intravenous drug misusers in the right side of the heart, but studies have shown that you can get them really on any valve, typically the aortic and the tricuspid. This person was in hospital for treatment of his infective endocarditis. So they'd put an intravenous line in his subclavian artery. Now, the problem with that in drug abusers is you're giving them free access. If they can get drugs, they'll just inject into the PIC line or the intravenous, CVP line, which is what. And he collapsed after he'd been visited by his girlfriend, and the suggestion was that she may have brought in drugs to him, and so they asked me to look at it because of potential criminal offences. Well, he'd actually got a mycotic aneurysm in his lung, so he's throwing off emboli into his lungs. He's developed this mycotic aneurysm you can see here. That had ruptured. He had a hemothorax. So he's actually died of the infective endocarditis, and he did have heroin on board, so he had actually injected himself, but it was coincidental. People who smoke, we see a lot of smoking of drugs now. It used to be crack cocaine. It's now fentanyl. People now smoke fentanyl. And so those pipes I was showing you, we call them crack pipes. We find them all the time now. But they're often, it's just fentanyl. Well, I say just fentanyl, it's principally fentanyl. We'll come on to that in a minute. And they have black lungs. Now, when I was a young pathologist working in Sheffield in England, I used to go 1 day a week to Barnsley, which is a town 15 miles north of Sheffield, where 50% of the population, male population, used to be coal miners. And their lungs used to look a bit like this. And that was why they would have black lungs. They would have pneumoconiosis. Now, when you see that, it's darker than cigarette smoking. They get chronic obstructive pulmonary disease from the crack cocaine. And if you do histology, you see these black pigments. So they're not the brown of cigarette smoking, they're black from the hot carbon burning that they're inhaling. And they may have pulmonary hypertension. Rarely injection, this is from intravenous drug misuse. You can get these nodules. I've only seen it in one case, actually, in my career. Certainly this impressive. But if you do histology of this, what you have are intravenous granulomas because they've been crushing up tablets and injecting them. And the sugars, the bulking agents in tablets obstruct in the pulmonary vasculature, and they can develop pulmonary hypertension. And I've got 3 cases which we're meaning to write off of people known to have this in hospital, documented arrhythmic collapse without toxicological, and they've actually died of the pulmonary hypertension secondary to their intravenous drug misuse. We see this less now, and it's because we used to get we had and I'll explain, but we used to have a lot of oxycodone abuse. So oxycodone is a medium strength opioid, and oxycodone was sometimes called hillbilly heroin because and it's the start of this opioid crisis. They were given out like Smarties, as we say. Smarties is it's a chocolate, almost tablet-like, sold in England. And they gave out massive amounts of oxycodone, and people got addicted because they said, the companies, Sackler's family, it was not as addictive as other opioids, and it was. And then people started to crush the tablets and inject them. So what they did was they changed the formula of the oxycodone to neo-oxy, making the tablets non-crushable, in the hope people would not inject them. And we have seen some movement away. The other thing you can see, this is a Movat pentachrome stain, and it picks up macrophages with foreign material, and this is perivascular. So this is someone snorting drugs, because that was the other thing. They would physically crush up the drugs and snort them rather than inject them. So another phenomenon you may see with cocaine and methamphetamine, they are stimulants and they cause a hyperadrenergic state, and you can get contraction band necrosis. So this is the myocardium, and these are contraction bands. And that is a classic thing. The problem is if they go into resuscitation, then you can get them from resus. But occasionally you see them in people who are found dead and have not been resuscitated, so we know it's a real phenomenon. This was a man that presented into the emergency department, known drug misuser, complaining of pain. That is a bad mix, because the doctors may think you are after pain relief, you want opioids, not for your pain, but because you are addicted and wanting to withdraw. And this person, the clinician said, we did miss this. He went into cardiac arrest, and what he'd got was, this is the superior mesenteric artery, and his thrombose is completely occluded, and he had small bowel infarction. And this is the histology, again, that pentagram. So here you have significant atherosclerosis, and normally the superior mesenteric artery is a rather protected artery. Doesn't get that badly affected by atherosclerosis. But he was a chronic cocaine user. So we did write this case up, and then on top of it, he's got the thrombus. And he was only 44. So, that's very significant atherosclerosis in an SMA for that. And then here's a classic case, brainstem hemorrhage and use of cocaine. So shoot up your blood pressure and then get hemorrhage into the brainstem. So because he had both acute cocaine and cerebral hemorrhage, we call that an accident, because there's acute cocaine use associated with the brain hemorrhage. He had a big heart as well. So he had chronic hypertension, he had bad coronary artery disease. All that we can say that the cocaine was accelerating it. So that's a sort of overview of the pathology we can see. I've taken some out. There are some other changes you will see. So in 2010, we started a new laboratory information system in our department. It's basically for the surgical pathologist, but we put our autopsy reports in there, so you can search it. And in 2010, we had 8% of overall. We've had 8%, and the figures I've got a little bit more. 8% of all our deaths have had fentanyl present. So, since 2010. Since 2016, it went up to 12%. In 2022, 18.5% of all our deaths had fentanyl in the cause of death. So you can see that there's this growing trend. And when I did this, and I've got some more updated figures, between 1 in 4 and 1 in 5 of every autopsies I did had fentanyl in the cause of death. And those figures will not include things like carfentanil. And I'll come on and explain all of these. And it will not include, say if you've got a homicide, let's say someone is shot dead, we don't get that, we don't get that many homicides. Ottawa is a city of 1 million people. I cover an area outside Ottawa as well, but in Ottawa itself, last year we had 25 homicides. So, nothing like what you would get in the United States, possibly slightly higher than, just under half our cases are shootings with handguns, but the handguns are illegal because you can't easily own handguns in Canada, unlike in the United States. Certainly all our handguns are illegally imported from the United States. Our suicides are typically long for guns are typically long-barreled shotguns and rifles, and most commonly for the rifles, 22s, but we do have some hunting rifles. And then stabbings, and then the odd beating and strangulation type case. But if someone, say, commits suicide, they hang themselves, we don't typically do toxicology. We store blood, but we don't do toxicology, and they may have had fentanyl use, so the fentanyl use may be slightly higher. So, some figures from the Canadian government. We were having 21 deaths a year, 21 deaths a day from drugs in 2024 across Canada, every day. 73 emergency room visits per day, and of those, 16 required hospital admission. 79% of our drug-related deaths involve fentanyl. But 65 also involve the co-use of a stimulant. So what these people do is they take fentanyl and then they take cocaine or methamphetamine. And it's a sort of downer and then an upper. And there's other things. And then we started to see some reduction in 2024, and it was an 11% reduction in the US and Canada. Now, this was a piece of graffiti that my autopsy tech photographed in Ottawa, and it's rather dark, and he wanted it dark. He was out walking, and he saw it, and it says, "We want all fentanyl." Hard. Soft, hard. Fentanyl is the drug they want. It's not heroin, it's fentanyl. The drug users like the buzz, apparently, of fentanyl. But there's a human side to this story. And this is an article from our state broadcaster, the Canadian Broadcasting Corporation. It's a bit like the BBC. And it says, so on the streets of downtown Ottawa, a hit of fentanyl can go for as little as $5. So if you have a beer here, that will cost you more than a hit, than $5. So it was cheaper to get a score of fentanyl than it was to go and buy a beer. So this woman said, it's a daily affair to take the drugs, and she said she's also overdosed twice. By overdose, she means she had to have naloxone, Narcan, to reverse it. I'm like, I can't breathe. So I reached over, I saw another Narcan, so I Narcaned myself. So they often, we give out, the safe drug use places give out naloxone, Narcan. Narcan's the commercial name. She said, living on the streets, the risk is too high to get clean. It's very difficult, of course, to break the cycle of addiction. And then this person said, he survived, by his own estimate, some 20 overdoses. So these people, despite knowing the risks, will continue to use. They need, there are significant costs to rehousing, rehabilitating, and removing people from their drugs. And we are just not there. And Canada is a rich country. But we do have safe injection sites, as we call safe use sites, although they've closed a couple down. Now, the other thing, of course, the point about all illicit drugs is they are not manufactured by ethical pharmaceutical companies. They are, and so he says that you can test them, 3% fentanyl, 97% unknown. You don't know what's in the drugs. And you don't know what you're putting in your veins. And I think at the bottom it said, started with OxyContin, which is oxycodone, there at the bottom. So these people started, often they got addicted to medically prescribed opioid, because oxycodone wasn't being manufactured illicitly, to my understanding. But there is a trend away from injecting, which in one sense is good, because there's more risk from injecting, to smoking. But smoking can still kill you with fentanyl without any problem. But here's the problem: in supervised consumption sites, you can't smoke because of other issues of spreading the drug. So in Ottawa, 2018, we had 82, 2019, and then 124, 144, 140, and that's cities stats. We cover a slightly larger area as well. What happened around here for that jump? COVID. And what happened in COVID was we started, giving out unemployment benefits for everyone because a lot of people lost their jobs, and people became isolated. So that people were probably taking their drugs on their own, whereas in the past they might have taken it with friends who would look after them, fellow users. So this is from the province of PI, Prince Edward Island. That's a small island off the east coast of Canada. It's a beautiful holiday place. I'm going there in a couple of weeks for our annual holiday. It's its own province. It's got about 140,000 people. And they were saying the concerns were that sedatives were being added to the drugs, and naloxone doesn't work on sedatives. So that was the story. What the sedatives are benzodiazepines. Now, a colleague of mine did some studies, and we don't think the benzodiazepines make much difference. It's still the fentanyl that's killing these people. Ordinarily, as you may know, benzos are safe. Pretty safe in overdoses, if that's all you have. But if you have alcohol or opioids on board, they're not. So this is sometimes known as benzodope, and one of the first we saw was a benzodiazepine called bromazepam. You won't find this prescribed anywhere. So it's not manufactured for prescription purposes. It's illicitly manufactured for the drug use. And this was an article from Northwest Territories, so our northern provinces, sparse, populated. This is from a small community, but there's concerns, fentanyl is spreading, or was. So let me give you some cases in the last few minutes. 28-year-old male using fentanyl and alcohol with a girlfriend and he was found dead in bed. The girlfriend finds him dead in the morning. The lungs are very heavy. That's a typical opioid phenomenon. They get pulmonary edema. It's not specific. We do vitreous in every case. His hemoglobin A1, and we measure hemoglobin A1C as part of our metabolic studies. That's by definition, and for those who are interested, hemoglobin A1C is stable post-mortem blood, because of course all you do is you lyse the red blood cells to do the analysis. So that's kind of what happens post-mortem anyway. So 6.7 actually means he's diabetic, but he wasn't known to be. But his beta-hydroxybutyrate is whilst it's towards the upper end of normal, and he's not got elevated glucose. Often you get no glucose, so there's a little bit there, but it's not enough for us to be diabetes, as you'll see. His fentanyl was 10 nanograms per mil, and he had ethanol on board, alcohol, 71. We always measure in milligrams per 100 milliliters. If you do it, that would be, 0.07 or something, if you do it in the other units. Clinically, they measure millimoles per liter, just to be very confusing. We detected bromazepam, but at the time, our tox lab didn't have a method for quantitation. They just said detect it. So the question is, what's the cause of death? Fentanyl and ethanol are enough to account. Do you add the bromazepam? Well, we didn't when we either had it unconfirmed or just detected, because we didn't know how much it was and what it meant. But our stats people said we would prefer you to put it in the cause of death so we can track, because they track on cause of death, our Statistics Canada. But there's bromazepam, a benzodiazepine. Now let's have a look at another case. So we got a 42-year-old male with a history of intravenous drug misuse and unstable diabetes mellitus with admission for DKA. So because this is a very vulnerable population we're dealing with. And that combination of being an unstable diabetic and using opioids is a very bad mix. drug paraffin and green fentanyl at the scene. Now, green fentanyl, what the drug dealers would do is they'd color the fentanyl. They'd put food dyes in it, so we'd have green fentanyl versus purple fentanyl versus orange fentanyl. It was all fentanyl, but it was a marketing trick. And people who were using it may be more familiar with, oh, the blue is good, I'll use that. Autopsy revealed track marks, a pulmonary abscess, changes of diabetic nephropathy. BMI was 20.3, so he's a little underweight. Toxicology revealed the fentanyl at 28. Methadone, so often these people are in methadone programs to try and treat them, but they still use. 7-amino clonazepam, so that's the metabolite of clonazepam, the prescribed benzodiazepine, but no clonazepam. Traces of acetone and isopropanol in the blood, but his biochemistry showed a hemoglobin A1C 11.3, so he's got poorly controlled diabetes. His glucose is 57.9, and his beta-hydroxybutyrate was 15.5. So, is he fentanyl and methadone toxicity? Remembering I've just got a fentanyl now that's nearly 3 times the previous one. Or is he diabetic ketoacidosis? Well, I said I think it's tolerant use of the fentanyl and the methadone, but he's died of the DKA, and there was histological correlation. He had subnuclear vacuoles. Some people would have said diabetic ketoacidosis in part 1, and in part 2 of the death they would have put the drugs. But we know there are plenty of people walking around with fentanyls of 28. This is the problem of post-mortem interpretation, but there aren't people walking around with beta-hydroxybutyrates of 15 and glucoses of 57, very much in comparison. And that was the rationale I did for that. So here we have a found dead, fentanyl 23. Now we've got cocaine and benzoylecgonine, so the metabolite of cocaine. Very high benzoylecgonine, and as you may know, cocaine converts to benzoylecgonine post-mortem. So we actually don't know how much cocaine. We know it was higher than what we have, but exactly how much we don't know. It continues to be metabolized, even in the tube. Now we've got flubromazepam, which is another one of these synthetic benzos we come across, but they've only unconfirmed for naloxone and unconfirmed for phenpyramine. The reason why it's unconfirmed is our tox lab have only run 1 test, and they have enough. If we wanted to confirm it, we'd have to send it away to another lab, pay money for it, and it wouldn't really change much. So fentanyl and cocaine toxicity, which is all fine, but what happens if you want to prosecute the death for dealing in fentanyl, which I'll come on to? Because the defense will say, well, it's all due to the cocaine toxicity, but the fentanyl was tolerant use. Female, found dead at home. She'd had a history of squamous cell carcinoma treated. She has an old myocardial infarct with aneurysm formation, 80% stenosis in her coronary arteries from atherosclerosis. But she's a known cocaine user, so we did that, and we found that she's got cocaine on board. So the cause of death was acute cocaine toxicity with atherosclerosis in part 2. That's a fairly typical story we see. People continue to use their cocaine. What is the slightly surprising thing about this? They were 77 years old. So there's no age limit to people using drugs. And we commonly see people in their 70s with heart disease using cocaine, which is a bad mix. Here's another fun one. A person, he's involved in a vehicular collision. He gets fractures to his legs. He's in hospital. He suddenly becomes agitated. He has a generalized tonic-clonic seizure, goes into cardiac arrest and dies. He was known to have a history of substance abuse and was on methadone. And the concern was a friend had come into hospital and supplied him with drugs. Now, because he was in hospital, I've got access to multiple blood samples. He was on 95 milligrams of methadone a day. That's a lot, but people can tolerate that. He's on pregabalin, tramadol, which is a painkiller, and methylphenidate, that's Ritalin for attention deficit disorder. And in hospital, he'd been prescribed some amphetamine and the anti-nausea drug. On the day of his death, he was re-prescribed stuff. So basically, I grabbed samples and said to my top, I had to ask them nicely, could you just run a series of tests on different blood samples? So and this just illustrates some of the problems of interpreting things. The pre-serum collapse, he has hydromorphone, so that's a medium-strength synthetic opioid. He's on methadone, a perfectly therapeutic concentration. Tramadol, ketamine, which is given in hospital but is also subject to abuse. He's got a low dose of amphetamine, but we know he's been prescribed it. They detect lidocaine, pregabalin, acetaminophen, diphenhydramine, not detected, and no fentanyl. And then post-collapse, they took blood. Now you've got a slightly higher hydromorphone, a higher methadone, and so on. Fentanyl not detected. And then post-mortem blood, and he's not been prescribed anything since. His hydromorphone is now 72. His methadone, which was 0.2 before the collapse, is now 1.4. And I wrote up a paper years ago on methadone. That would easily allow people to say he's died of methadone toxicity. And you've got traces of fentanyl. So this is a good illustration of post-mortem redistribution of drugs because we've got the pre and post samples. And actually, the only reliable ones are the a comparison of the pre and post collapse, not the post-mortem. And it doesn't really point towards a drug overdose. It's certainly not fentanyl. Where's the fentanyl come from? Fentanyl stores in fat and will come out of fat into the blood post-mortem. And we know you can have massive changes in fentanyl concentrations. Any idea what he's died of? Fat embolism syndrome. That's actually what he's died of. He's died, and that's why he's got the clonic tonic agitation. And I checked the medical records, and other biochemistry then fitted. So, in all of this, a few more minutes. There are people in Canada and the United States who say because it's so prevalent, we're so busy, we will just draw a blood sample where the circumstances are good. Now, I've just shown you the problems with that. You've got post-mortem redistribution of drugs. You may have pathology inside. The New Mexico data and then a paper out of the Carolinas said you're probably going to get about 11%. We'll say 1 in 10. You'll get 1 in 10 of your causes of death wrong if you just do an external examination and draw blood. And would we accept 10% error rate in laboratory medicine? We would not. That's way too high. You know, the standard error rate you accept in a surgical pathology laboratory is under 2%. We don't want any errors. And no one's really ever looked at error rates in forensic pathology. I mean, we've done a little work in Ontario. The other problem is, in North America, you can prosecute the dealer for the death of the person, not just the dealing, but you can prosecute them for manslaughter. And there are cases now coming up. And the problem that we've got, here's one recently. I've got methamphetamine, fentanyl, xylazine, which is a veterinary medicine is appearing, bromazepam, fluoronyl UF17, dexmedetomidine is present, naloxone's unconfirmed. We are getting multiple drugs in these cases. And here's a 29-year-old woman I did early this year, I think it was about February. There's carfentanil in there. We'll talk about carfentanil a bit. Fluorofentanyl, which is another variant of fentanyl we began to see a couple of years ago. We've got use of stimulants. This substance, desalkyl gidazepam, is the metabolite of gidazepam, which was a synthetic benzo manufactured in the Soviet Union. Not prescribed to my knowledge, but appearing in our drug population. And so we have the opioid strengths. If morphine is 1, methadone 5 to 10, it's a bit variable because of its metabolism. But here's the thing about carfentanil. So fentanyl's is about 100 times as strong as morphine. Carfentanil is 10,000 times. And the point about that is then that you've got very small window in the dosing. Carfentanil is used for knocking out rhinoceroses and elephants. It's a veterinary opioid, but it's in our drug-abusing population. Nitazines are synthetic opioids that are beginning to emerge in Europe. We haven't seen, but we've had one case in Ottawa with I think just a metabolite. They're about 800 times as strong. They think fluorofentanyl may be twice as powerful as fentanyl. These are obviously what matters is the dose combined with the strength of the drug. But you can see these are extraordinarily powerful agents. So how do we determine when is a drug fatal or has it redistributed? How do we determine how tolerant someone is? And the answer is we can't. Is there a better matrix for the use of toxicology instead of blood? Because blood has its problems, but it's the standard test. And, some people are not doing full autopsies. So the trends, I've just put this in, we've had 1,000 fentanyl cases in the last 15 years with it in the cause of death. Oxycodone, 103, hydromorphone, 231. So these are the two. These are commonly prescribed painkillers. Carfentanil, we've had 120 deaths with carfentanil. So, and that first appeared in 2017. Fluorofentanyl, we've had 120, but it only appeared in 2023. Bromazepam first in 2022. Etizolam, which is another synthetic benzo. Cocaine, we've had 1,200. So we've actually had more cocaine than fentanyl, and then methamphetamine, but they'll use them all together. So that gives you an idea of the sort of patterns of drug abuse that we are seeing. Your pattern may be will be very different. I know from brief conversations it is. But we've seen a fall off. Our peak was 2019. We had 82 cases between January and June of last year, and then 43 from July to December. So there has been this fall off. And this year we've only had 8 of 265 cases signed out. What's happening? We don't know for sure. The Americans seen this. It could be a combination of drug seizures that have just temporarily reduced the market. Possibly the market's been killed off a little. If your drug users die, they have to be replaced. And if people are not coming into, it's like the smoking story. If you don't replace your smokers, the smoking industry goes away. And it could also be the wider distribution of naloxone with people being resuscitated better. It could just be a change in the pattern of use in terms of moving away from injecting to smoking, maybe smoking less. We don't know for sure. But that's a relief, and we've seen a significant drop in the numbers. Very quickly, they prosecute now in North America, and there is a law in the States that if you, the dealer, give somebody fentanyl, any drug, but fentanyl, and they die, the typical American sentencing, there is a minimum sentence of 20 years in prison. Minimum. Should dealers be charged with murder? There's a talk of that, which of course is much more severe. That will get you life imprisonment. I won't read all of this, but I basically did a 17-year-old woman who'd been supplied fentanyl. She'd also taken methamphetamine. She has 16. She has no natural disease. She's 17. I put the amphetamine in, although it's quite small, but there's kind of no safe concentration. But the principal factor was fentanyl, and they prosecuted the dealer for manslaughter in Canada, I think partly because she was 17, so young. And I'm not going to go, but it says, Dr. Milroy, and this is a written judgment of the court, so that's why I can read it. It was a judge-only trial, no jury. Determined the cause of death was fentanyl overdose. You know, and the question was he dealing? Was he responsible for the death? And she went through the evidence, and basically she says, had Derek not provided Rachel with fentanyl to consume on the 27th of August 2021, she would not have died. Provided the fentanyl, therefore I find that the actus reus, meaning the physical act of manslaughter, was proven. So in common law, we talk about an actus reus, Latin, the act, and then the mens rea, meaning the mental element of the crime. Is there a guilty mind? And both were proven. He was sentenced to 8 years for that death. So interestingly enough, though, because we're a common law jurisdiction, they've looked at this in England and Wales, and I won't go through it all, but this case went through multiple iterations right up to what is now the Supreme Court. He had supplied a syringe containing heroin, which the victim had then voluntarily injected. And what the House of Lords ruled in England was, if you voluntarily take the drug, it breaks the chain of causation for your death. And the dealer is not responsible for your death if you voluntarily take the drug. So in England, you cannot prosecute the dealer for the death. You can prosecute them for the dealing, and that carries very stiff sentences, but you can't prosecute them for the death. And that makes life easier for us. What New South Wales has done, because of the jurisprudence out of England, and common law jurisdictions will look to other common law jurisdictions to see how they handle it. And especially the English, the Canadians, and the Australians will look at how the legal reasonings, and they followed the legal reasonings of the House of Lords, and the way you get round that is you pass legislation. And they've passed legislation in New South Wales, so that's the state in Australia that's got Sydney, the city of Sydney in it. You now can have a maximum of 20 years if you're shown to be dealing. Now, the problem for us as pathologists with the mixed drugs is which of those drugs really killed. Now, we put all of them down, but the defense will argue that the cocaine was the cause, even though you've been charged with fentanyl trafficking. And it's, in one sense, hard to argue against that. I mean, the others as well, look, they're all there. They all contribute. And as long as they all contribute, that's enough to say that the death. So I've had 2 or 3 deaths in Canada where they've prosecuted, but it's literally 2 or 3. And you've seen I've done over 1,000, or my colleagues have. We've done over 1,000 fentanyl deaths, and we've had 3 prosecutions that I've had knowledge of. So it's not a solution to stopping drug dealing. It's a minor, you know. The criminal justice system is not the place to deal with. I mean, it has its role, but there's a medical role to stop the opioid crisis, and there's a societal roles, not just the criminal justice. So that is a very quick run through of deaths and from drug dealing and our opioid crisis, and I can answer any questions if you have any. Thank you. Any questions? You don't have to have, but one thing I would say, you notice I didn't talk much about heroin. We really don't see very much heroin in our population. In England, it was all heroin, and the stimulant drug was ecstasy, and I wrote about that years ago. We see a little ecstasy in Canada. We don't see much heroin. There's a little, but not much. And the fentanyl deaths really kicked off in about 2014, where we had illicit fentanyl manufactured in China, as I understand it, in China and Mexico illegally, and then transported to the US and to Canada. Well, do you want a couple of? Oh, yes, please.
You mentioned the uprise in fentanyl cases. You mentioned, I believe, 8% in 2010. And then
Yeah.
there was an uprise to 22% in 2023.
Yeah.
The cases you meant, those were the autopsy cases?
They're all autopsy
Yes,
cases. So we don't do clinical forensic medicine.
Okay. So can you maybe mention what are the indications for the autopsy? And I have the indications for the autopsy changed over time, so I can maybe imagine the numbers.
Yeah, well, so one of the changes, so when I said I did fentanyl litigation, and I didn't really go into this. When I first went to Ottawa, the source of the fentanyl was fentanyl patches. And they were diverted fentanyl patches. So people would get hold of the patches. So the patches are put on your skin for chronic pain. People would scrape the fentanyl from the patches, or they'd mix it and inject it. And that supply was limited. And so we were seeing that. And we occasionally, people would come in and they'd have fentanyl patches. And there's a whole literature on drug levels and fentanyl patches, because that's complicated. What then happened was we started seeing illicit powdered fentanyl come into the market. And the autopsy findings are non-specific, but they are pulmonary edema, froth in the mouth. If they're using cocaine, and they have been using cocaine a lot, then you might see an enlarged heart. You may see more coronary artery atherosclerosis than you'd expect for the age. You may see injections sites, but a lot of it's smoked, so you may not see much, but they may have this black lung indicating a habit of smoking both fentanyl and cocaine. And on histology of the lungs, in the fentanyl overdoses especially, you may see some early bronchopneumonia. You may see a bronchitis, sort of inhalational bronchopneumonia. So it's worth looking at the histology of the lungs in these cases. And that can help sometimes when you're not sure about how significant the blood concentrations are. So my normal practice is to, we do a full autopsy on these. We do histology of the major organs. We do biochemistry on every case, vitreous, but that's partly because we have a lab that will do it for us. And we send our blood for toxicology to our government laboratory. So that's our practice. And, it was, in 23, we just kind of go, oh, fentanyl, oh, fentanyl, oh, fentanyl. We got very sort of another fentanyl death. But as I say, this year it's fallen off. Okay, do you want to stretch your legs for a couple of minutes, and then I'll go on to the next, my final talk, which is principally about vascular trauma in forensic cases in the neck and head. Okay. And so this is slightly different. So I'm going to talk about vascular trauma, particularly to the neck. We do not have access to a CT scan routinely in Ottawa, so we don't do post-mortem CT. On average, we keep about 40 brains a year for formal neuropathology, about 4%. Additionally, I sometimes retain the brain for a couple of days and then cut it and then return it to the body. We tend to use 20% formalin for those cases, and that helps fix the brain a bit better. But in Toronto, we don't always examine the heads because we do post-mortem CT. Because they're actually, say, for drug deaths in Toronto, if they've not got cerebral hemorrhage, then we're pretty sure there's not going to be nothing in the head. So that's a post-mortem CT. That's not a normal brain, though. If you've not seen it, that is that's a decomposed brain. And that's what we call Swiss cheese in English. Seen the term Swiss cheese? Well, that's what it looks like on a post-mortem CT. When we see that, we don't open the head in Toronto because you're not going to see, and there's nothing else there. And of course, neurotrauma, I'm not going to go through all of this. You know, we're looking at scalp injuries, skull fractures, extradural or epidural, depending on. The English call it extradural, the North Americans call it epidural, so that's the Canadians and the US Americans. And then obviously we're doing the different types of things. And what I'm interested in today is vascular injuries. Now, classic vascular injuries where you get a fracture of the skull crossing the middle meningeal artery, and then you get your extradural. And this was a case I did where we recovered they did a craniectomy, and we had to recover the skull from them, which is why from the surgery. But there you can see the fracture and the site where they had done the neurosurgery. And obviously you can have an acute subdural. This is interesting. This was a case I did in Toronto. So this is a post-mortem CT. And you can see you've got hemorrhage on both sides. So, you know, that's why we know when we look at CTs, and we the pathologists do it, we don't have radiologists doing it, because in Toronto they're doing 7,000 a year. We can't afford radiologists to look at those, and we don't need to. Well, that's actually bilateral epidural hematoma. What do you get bilateral epidural hematoma in? You get it in fire deaths. So that's the heat hematoma on a post-mortem CT, which I thought was a rather neat case. Now, just the thing, you know, when you've got cases, sometimes not everything that, as the English expression is, not everything that glitters is gold. And so, in other words, we have to sometimes investigate these things a bit more. This is a case I did just at looking at the vascular. This is a subdural. Subdurals are traumatic, and subdurals are traumatic unless they're not traumatic. And this was the histology of this. So there's some hemorrhage in the substance of the brain, which is unusual. And this is a Gram stain. You'll notice all the Gram-positive cocci. So this was actually an infection causing subdural hematoma, and the clinical circumstances did not fit trauma. So there was a subdural that actually was from, it was, I think it's a streptococcus. And just to say, you know, fixing the brains for, sometimes there are conditions you're only going to pick up on careful neuropathology. This was a young man who had a history of collapses, and he'd been investigated. We looked at his heart, we did genetics, it was negative. What he has is he has a lipoma above the corpus callosum, but he also has a lipoma below the corpus callosum. You'd probably almost certainly miss this if you cut the brain fresh. And now that's a decision you have to make sometimes, but I happened to send this one to a neuropathologist, and we had a discussion. Oops. You can see the lipoma. But I just wanted to show you, that is in the position you can sometimes see colloid cysts in, and they decided it could be causing obstruction. And taken with the history of the collapses and the negative heart, that's what we decided the cause of death was. It's a subcallosal lipoma. And in my career, I have seen hundreds of these. No, this is the only case I have ever seen. So it's a rare, and you could even argue it may or may not be the cause of death, but this is what we had, and it was done by a neuropathologist. And so there's your lipoma histologically. The supracallosal lipomas are common and are an incidental finding. They don't cause any problems. So, so just as a general approach, if we want to keep a brain, we have to inform the relatives. And so we have a conversation with them. Sometimes they object. And depending on the circumstances, we may accept that rejection or we may not. If it's for finding sudden natural death, we may say, well, you'll never have the answer. And therefore we'll cut the brain fresh. But usually, in that case, I can persuade him to let me hold the brain for 48 to 72 hours. That makes the brain quite stiff, reasonably able to cut. It's not ideal. So investigation of vascular injuries to the neck. So, as you know, both anterior and posterior, carotid arteries in the jugular complex, posterior vertebral arteries and veins. Particularly going to talk about vertebral arteries. And I'm not going to go through the anatomy. You kind of know it, I hope. Mind you, students don't get taught anatomy in the way we used to be, whether that's a good thing or a bad thing. I have a friend who was a professional anatomist, and he said to me, Chris, a lot of the anatomy we taught was actually not much use to most doctors. And if you needed to learn the anatomy, you learned the specialist anatomy that matters to you as a specialist. And that applies to forensic pathologists as well. So we don't need to know so much about the origins and insertions of all those muscles and the pathways of the nerves in the arm. If you're an orthopedic surgeon, you do, but we need to know about the vasculature of the neck. So carotid arteries and jugular vein complex, important in stabbings and pressure on the neck. So actually, interestingly enough, when we have strangulation cases and we're not 100% sure of the mechanism of whether it's hands, whether it's a broad ligature, whether it's an arm lock, we certify those deaths as compression of the neck. And then we discuss potential. And that way, you're not limiting yourself if it's not strangulation. So, the standard thing, of course, in the front of the neck is to do a neck dissection in an avascular field. That means, for us, we take out the organ block, we take out the brain, and then we dissect the neck in as avascular field as possible. And here you can see that there is bruising over the voice box, the laryngeal cartilage in a compression of the neck case. And then stabbings, we will do the neck dissection in stab wounds to the neck. And here you've got the carotid divided in two, which is not a healthy thing to happen to you. Here's an interesting case with the hanging. There's a little blood from the nose. Did this many years ago in Sheffield. Classic hanging ligature, classic hanging ligature mark. He had a little bit of blood coming out of his ear, and that can happen. But when I did looked in the neck, you can see he's got a completely separated carotid artery and no bleeding. And it's because of the immediate constriction of the brain. Now, you rarely see this, and typically now, we don't do internal examinations on our hangings. Typically, we do external examinations. If the scene is correct, so someone found hanging at a scene, history of depression, maybe a suicide note, locked apartment, we'll often just do an external examination, we'll draw blood, and we'll leave it at that. But just to prove, let's just go back, why this person has a pale face. They used to, in the old literature, sometimes they said it was due to vasovagal inhibition. It isn't. It's complete obstruction of the carotid artery and the jugular vein. There's no blood coming up, so they don't get congested, they stay pale. And as I say, in this case, with the rather dramatic complete separation of the artery. You occasionally get thrombosis, and in this case, it was actually a case, I think, where a man was haggling over the price with a prostitute and wouldn't pay her, and she grabbed him by the neck, and he had atherosclerotic disease in his carotid, and he thrombosed it, got a stroke and died. So it was a homicide, but it's a somewhat unusual one. That's in our book, I think, which I'll come on to. So the front of the neck is relatively easy. I think, you can see things, but, you do your layered dissection in an avascular field, and you can dissect out the carotids and the vagus nerve and the jugulars, whether it's penetrating trauma or whether it's compression of the neck. But the vertebral arteries are more difficult. You may have delayed presentation, and you require special techniques to identify. So here and it's because they're encased within the vertebral column. Now, it's interesting. I was talking to my co-editor of our book. I'll show a picture of our book later, on neuropathology, who's Daniel Duplessis, who is a forensic neuropathologist. So his background is as he's a practicing neuropathologist, but has an interest in trauma and forensic cases. And in the book, because he writes the chapter with an old friend of mine, we were at medical school together, called Paul Johnson, Christopher Paul Johnson, to give him his full name, who've written a lot on vertebral arteries. And it used to be said that the rupture took place around here. They talked about the C2 lesion. But actually, this is nonsensical, because all the hemorrhage is in the basal subarachnoid. So we now know that the traumatic subarachnoid, which we're going to talk about, is due to damage to the intracranial vessel. They're often just as they come through, and you need to look carefully in that area. But sometimes you get things happening further down. Come on to that. So how do you dissect? Well, you can do in situ, and some people do in situ radiology. So they'll put contrast medium. So what you do is you remove the thoracic organs and the abdominal organs. You find the origins of the vertebral arteries, and then you inject them with dye. That's the way I've always done it. Although I haven't done it for a while, with contrast medium. And you can you can dissect out, removing the arch of the vertebral artery so that you expose the artery. Or, if you're lazy, you can cut the whole thing out so that you've then got time, because these are fiddly things. And you can also do radiology on your en-bloc specimen. So you can inject your dye when you've taken it out, and you can do it in a faxitron or take it to your X-ray department. So you can take out the neck, and this is for pediatrics. There's been some work looking at shaken baby syndrome, pediatric head injury, abusive head trauma. You can pick your term. The logical term is actually head injury. Abusive head trauma is pejorative because it includes both a manner and a pathology. But the American pediatricians use the term abusive head trauma. I think that's prejudicial. And what they've said there in the pediatrics is you take it out, you fix it, you decalcify it, you slice it. And what they're interested in is looking at the nerves that run off the dorsal root ganglia. You can also, if necessary, completely dissect out and deflesh the neck. So here you have a case I did in England. That is the hangman's fracture. Now, this is the classic hangman's fracture. When we had judicial execution, this is not a judicial execution case. When you did judicial execution in England, which was abolished in the last executions were in 1964, and it's now completely abolished. It was abolished in Canada around the same time, but they were all hanged, except for soldiers in the, soldiers in time of war were shot. And we shot we shot several hundred in the First World War. You get this fracture across and so the idea is that the knot was placed around the jaw. The hangman we had, Pierpoint, claimed he could hang someone in the time it took. They were hanged at 8 o'clock in the morning, and he said he could take someone from their cell and hang them in the time it took for the 8 bells to sound. Now, I'm an absolute opponent of the death penalty, but this is just history. And the forensic pathologists of Bernard Spilsbury at the beginning of the 20th century autopsied people and came up with how far you needed to drop them to fracture their neck. And the object of the exercise was to fracture their cervical spine and get distraction of the spine. So you occasionally see this, but we don't always look for it, in suicidal hangings if the drop is far enough. If you go too far, you actually decapitate them. If you go less far, then the death is due to vascular constriction, not due to disruption of the spinal column. That's the theory behind this. This poor boy fell out of a tree, and he landed on a fence, and he effectively hanged himself by judicially, by hanging, and got so that is the classic hangman's fracture. And you really only see it apart from bizarre accidents in historic material. We did look at some, interesting enough, I looked at executed criminals. We were allowed to exhume them because they were being moved, and we found a minority had this fracture, but there's someone who had done autopsies and executed criminals told me that you still saw disruption. So let's do some cases. Police and paramedics are called after a man was reported as unconscious. He was taken to hospital where he was in asystolic cardiac arrest. He's noted a past history of cardiac problem. It appears that a confrontation took place between the deceased and another man in the house, and he immediately collapsed following a punch. It is alleged that a woman at the house had hit the man in the eye region. There was a black eye, so periorbital hematoma, but in common English, a black eye, a red bruising of the upper eyelid, and some abrasions, and there was an abrasion on the bridge of the nose. Facial tissues, though, received a bruising in the angle of the jaw and over the upper right sternomastoid muscle. It's actually this side, but. And that is absolutely classical for rupture of the vertebral arteries. But I couldn't identify a site of rupture. However, bleeding was shown in the soft tissues around the right vertebral artery. So toxicology, he had alcohol on board, and that is the classic scenario we see. Now, interestingly, and so that is so what the theory is: you punch someone, their head rotates, they tear the vertebral artery just after the origin, and maybe my dissection wasn't good enough, and I should have done some more to try and find the ruptured site, but everything was acceptable, and they're often intoxicated. They typically have consumed alcohol. Now, there are various theories about the role the alcohol plays. One is that you can get changes in the difference between your systolic and diastolic, almost like a water hammer effect. The other, and probably more likely, is that the neck doesn't clamp as quickly, and it can stretch further in the punch. And these people punched and collapsed. Now, in England, I used to see this in my practice once every year, once every 2 years. I've not had a case convincingly in Canada, although a colleague has had. And one theory for the difference is the English historically stand up in bars to drink. And if you're standing and a fight breaks out, it's more, and it's more likely to break out. You're both stood up, you're intoxicated, and you get punched around the jawline. And in continental Europe and in North America, you tend to sit. And so that it has it's less common as a consequence. And there is, it's a wonderful phrase. Sociologists refer to the way the English drink and the Irish and the Australians as vertical drinking, which should mean there should be horizontal drinking as well, but it's known as vertical drinking, and it probably is why a lot of the cases are reported out of England, because it's just more common because of our, it's one of the things that forensic pathology is associated with social practices, whether it's drugs or even, or trauma or the incidence of guns, which is why you don't see gun crime in the UK in the way you do in America. Now, the first literature on the traumatic subarachnoid hemorrhage, as it's known, came in the 1960s. And it was reported out of, I think, Denmark, and then the UK did a lot of work. I think I have found the first case in the literature, and it's from 1830 something, and it was 2 alcoholic Scots people, and the surgeon who did the autopsy describes bruising around the angle of the jaw in the soft tissues and diffusion of blood in the base of the brain. And I'm pretty sure that was a traumatic subarachnoid hemorrhage, and I think I've found the earliest case. So I used to do with these. So man involved in the fight, hit in the head, bang to the floor, cervical muscles, bruising in the left sternomastoid, and bruising on the left side of the face and neck. This is all very typical, but nothing deeper. But bruise on the forehead, bruise to the occiput because he's fallen back onto the floor, bruising and swelling of the left ear which extended to the eye, skull intact, and typically there's no fracture in these cases, and then basal subarachnoid hemorrhage, and this is the classic thing. So basal subarachnoid, after a fight, you're going to have a ruptured, you're going to have a tear in the vertebral artery somewhere. And I identified damage to the left vertebral artery. Blood alcohol was 293, so it's getting up there. Although, I mean, you look at that figure, so your legal limit for driving, I'm guessing, but it's almost certain it will be 50. 0.05, is that your legal limit for driving in Slovakia? It's probably going to be that. It's 0.8 in Canada and England. But they arrest people driving with blood alcohols over 300. So it shows the tolerance among alcohol, it's a... And this is your typical picture, your basal subarachnoid. And the question that will be asked is this from a ruptured berry aneurysm, or is it, and if it's, but if there's a traumatic history, it's almost certainly not going to be from a ruptured berry aneurysm. But your job is therefore to go and look. Now, one of the things you can do, I sometimes do in these cases, because I know it's going to be, it's likely it's going to be a tear in the vertebral artery, I tie off the basilar artery with string, I cut the cerebellum off at the level of above the brainstem, and then I then cut out the neck, keeping all of that intact so that you can then inject. Or the other thing you can do is add autopsy. You can inject into the vertebral arteries and look for where the leak is. And you can use colored fluid. Another thing you can take is milk. Milk's quite useful. You just take milk because it's white and it comes out, and they come out of the hole. And then you take that and you do histology on it. And so you want to clean off the basal arteries, the circle of Willis, to see that there's no berry aneurysm. Because the tear may be just coming into the, often it's around the base of the brain, so not always easy to see until you dissect out. So you can dissect out the vertebral artery. This is it in a more clean form. But I've seen people, see there's a nice tear, but that's me making damage during the dissection. And I've seen people say, oh, that's the site of the tear. It's illogical to be there, and there's no blood around it. So I've seen artifacts called that. So if you orient it to yourself, this is the base of the neck. You're coming up and it's going around. This is the sort of C2, C1 area before it goes up into the base of the brain, which is there. And so I cut out around the base and removed the whole neck. And so you do histology, and here and you can just see this is the rupture, and you can see a hint of fibrin. I forget which stain this it was now. You can see a hint of fibrin at the place of rupture. And so that was lucky or, skill, take your pick. But I was able to find it and was very pleased to see it. Occasionally you get delays. So this person survived in hospital. There's the vertebral artery. Oops. And he's got thrombus over it. So it semi-sealed off, but he died. He was on a ventilator for 2 or 3 days, and then he died. That's uncommon. I mean, these incidents are uncommon, and this is doubly uncommon. This is one of the first cases I did as a forensic pathologist. This was, was it? Oh no, one of my first cases I did was actually a woman who died in a car crash. Her boyfriend had gone through a red light. He was intoxicated. There'd been a collision, and what had happened, I think, was that he had been thrown over and head-butted her on the side of the jaw. And so when I did the post-mortem, she had a ruptured vertebral artery, but it was from a road traffic death. And there is some literature on them. But no, so this was one of the early cases I did in Ottawa. So this was a 30-year-old woman involved in a motor vehicle accident on the 5th of February, rear-ended while driving. So had headaches for several days and then was well. She presented to the emergency room on the 30th of March. So nearly 2 months later, with headaches and right-sided stroke symptoms, she was given TPA, so anti-thrombus medication, and had a massive bleed. Investigation showed a clot at the bifurcation of the basilar artery into the posterior cerebellar artery. Neurology suggested this was related to vertebral artery dissection secondary to trauma of her MVA. Well, was it? So the initial CT was described as negative, and then an MRI showed thrombus of the mid and distal basilar, and then she had irregularities in the right vertebral artery. And she had an infarction. So she died. The brain was examined in detail. It showed basilar thrombosis with cerebral infarction. Also, changes in the basilar artery were compatible with segmental medialytic arteriopathy. Meanwhile, I'd done the vertebral arteries. Sometimes my neuropathologists want them. Sometimes they're happy for us to do them. And so there's your vertebral artery. So you have dissection of the vertebral artery. And you have abnormalities in the vessel. And so my neuropathologist, very experienced, said he thought there was changes of segmental medialytic arteriopathy, and there they are. So this is an abnormal vessel. And she's got bilateral, not one, both bilateral vertebral artery dissection. So quite dramatic histology. And so Michael Polanen, who's the chief forensic pathologist in Toronto, who's had a big interest in vertebral arteries and done some work which we'll mention shortly, said the best thing you do is take the whole artery out and block the whole artery. So we take, I might put four or five sections in one cassette, but then take, 5, 6 cassettes so that you've got the whole of the artery embedded on each side. Just to show you, this is not a vertebral artery case. This was somebody I did. You have an aneurysm of the splenic artery. This person was 20 and suddenly collapsed watching TV. But he has segmental medialytic arteriopathy. And we don't exactly know what it is, but what I would do these days is I would do genetics. And the early case, we weren't doing genetics, partly because the cost of doing genetics has come down so dramatically that we're able to do it almost as a routine investigation. I say almost, in appropriate cases. So this is segmental medialytic arteriopathy. You can do some MOVAT stains. So this was, and so this can crop up in multiple vessels, but one is in the vertebral arteries. And I got involved in a case in another country. It's actually the only case I've ever had death threats from. Got some emails that didn't like what I was saying. And this person was a linesman, so an assistant referee in a soccer game. He was allegedly assaulted, and he collapsed 3 hours after the event. He'd driven his car, and he had vertebral artery dissection. After this, you can see the abnormality in the vessels there. There's a breakup of the internal elastic lamina. I had a dispute with who are friends of mine with the local pathologist as to whether there was underlying disorder. In one sense, it didn't matter in that, you know, if you hit someone, there's certainly in English, in common law, there is a legal dictum that you take your victim as you find them, otherwise known as the thin skull rule. If you hit someone and they've got a thin skull, and they fracture the skull and get a bleed, the problem is not the person with the thin skull, it's your problem for hitting somebody. I mean, that makes logical sense. In other words, you know, if someone is vulnerable and you hit them, the vulnerability does not help you. So, abnormal vessels and, you know, findings, that was sort of my findings. And we had a debate about whether there was an underlying disorder, whether the trauma. The problem I was arguing is you don't know what happened in the, well, I said, I'm not arguing, I just pointed out, we don't know what happened in the 3 hours between the assault, which was probably a kick to the head, and his driving, and we'll come on to that. Now, so there is some interest in this. Michael Polanen has looked for Ehlers-Danlos and Marfan's in these cases, and there are, he's had a case with abnormalities in the COL3A1 gene that we tested for. And now you can test for that reasonably, for us, reasonably easily. And so what would happen if we have one of these cases, either the bilateral vertebral artery or a rupture, is we would test. And the reason why we think that there may be an underlying genetic abnormality is quite literally hundreds of people, if not thousands, must be punched in the face of a weekend in a country the size of the United Kingdom in bar fights. Very few of them rupture their vertebral artery. So is there some underlying risk in the people who get the rupture versus those who don't? But Michael Polanen and Michael Pickup showed that. And and a clue is also you can see segmental medial atrophy and a thing called fibromuscular dysplasia. And the point is that the vertebral artery dissection, certainly, not the ruptures, but the dissection has been reported in the following things. So these are the things to avoid: yoga, trauma, painting a ceiling because your neck is coughing, sneezing, vomiting, receiving an anesthetic where they manipulate your neck. So a classic thing in North America is chiropractic neck manipulation. Why on earth you'd want to have your neck manipulated? I mean, it's quack science anyway, in our opinion. Minor falls, motor vehicle collisions. Even apparently turning your head to reverse a car can do it. So it has been, vertebral artery dissection has been reported with lots of different things. And I was just pointing that out to the court. I think they still convicted, which is perfectly reasonable. That's their decision. So you may, but so you grab the arteries and but take both sides, and you look for it. So there's the vertebral arteries. You can see the abnormality there in the internal elastic lamina of the pentachrome. So traumatic, typically a punch around here. But I've also seen it, as I say, in a motor vehicle collision. I also had it with someone who was hit in the side of the head with a spade, and they probably had their neck rotated as it was happening. So this was, and then bilateral vertebral artery or unilateral vertebral artery dissections occur. They may be traumatic, they may be non-traumatic. You need to dissect out both sides and do histology, and nowadays we would certainly think about doing genetics on them. So this, to finish I think, traumatic, and then I showed that delayed rupture of on the vertebral artery. So this, I'm going to show a case of a delayed death following trauma. So uncommon to get traumatic aneurysms in the head, said to be more common in children and males, reflecting an incidence of trauma. You know, men do stupid things, that's the bottom line of it. And they can be from blunt or penetrating trauma. Now, you may have direct trauma, or it may be, you know, stretching of the vessels. They can be proximal to the circular willis, so, or they can be distal. The clinical presentation can be with hemorrhage, neurological deficit, seizures, acute loss of consciousness, and a variable timescale. So, you know, here's the thing, and you see, that's another thing about vertebral artery trauma. It's very rare in boxing. And yet they get punched around the head all the time, and it may be because A, they've got their neck muscles built up, and they're not intoxicated when they box. It has happened, but it's rare. So we think, you know, related to rotational acceleration, stretching. So true aneurysms, oops, let's go. True aneurysms, you maintain your adventitia. False aneurysms, you get a rupture and then the blood goes into the wall. So partial or, then you can have partial or full thickness laceration of the wall versus the expanding from the aneurysm. So Kenneth Peskin, who was in Melbourne in the forensic department at the time, you know, traumatic would require proof of their formation after head trauma by comparing pre- and post-mortem angiographic studies. Well, of course, that typically doesn't happen. Differentiation from a natural berry aneurysm, Ken laid out its peripheral location, site away from branching point, irregular outline of the sac, absence of a neck, delayed filling and emptying, this is on radiology, of course, location adjacent to the falx edge. And so here, I think I'm trying to show a berry aneurysm. There we go. Which we can see. And so, you know, when you dissect, one of the things, by the way, if you, especially for the more junior pathologists, if you have a basal subarachnoid hemorrhage and you think there may be something, do not fix the brain with the clot present because it turns to concrete. You need to remove the clot and then you need to dissect out the arteries. And you can do that fresh. And that's what I've done here. So I dissected them out, and there you have a berry aneurysm. And most berry aneurysms that rupture are less than 1 centimeter in diameter. And so you'll find them, you know, in various places around the circular willis. But this is a case I did in Ottawa soon after I arrived. He went to break up a fight and was struck at least once in the head. And he may have just been caught in a punch that was being thrown at the other person, but walked into it, and rather than being the direct. In law, it wouldn't matter if someone's throwing a punch. There's the doctrine of what we call transferred malice. Interestingly enough, when the paramedics arrived, he had a Glasgow Coma Scale score of 3/4. He required respiratory support. His pupils were dilated and deviated to the left. But at hospital, his Glasgow Coma Scale score was 14. And I think he's had one of these primary brain apneic attacks that we're beginning to recognize more. What happens is they maintain their cardiac circulation, but they stop breathing. And it's typically probably blows that are affecting the brainstem breathing centers. So he was intubated and then he was extubated on day 2, but he had headaches, but his Glasgow Coma Scale score was 15. They did imaging, and on day 1, they noticed that he had diffuse moderate subarachnoid hemorrhage and intraventricular hemorrhage and mild hydrocephalus. A CT angiogram was performed. No evidence of an obvious aneurysm or fistula was reported. No evidence of vasospasm was seen. On day 2, they re-CT scanned him, and he had slight progression of the hydrocephalus. Day 7, they noticed he had minimal residual blood in the right occipital horn. The previous subarachnoid hemorrhage had completely resolved. It shows that, how quickly it can go away. But they noted that he had a 1 millimeter aneurysm at the origin of the left posterior inferior cerebellar artery, is pica, as we call it, refer to it in North America. Normal appearance of the rest of the cranial arteries. There was no other aneurysm or arteriovenous malformation. And otherwise, his Glasgow Coma Scale score is 15. So on day 9, he was fully mobilizing. He went outside the hospital for a cigarette. You're not allowed to smoke in hospital grounds. And he collapsed and had a Glasgow Coma Scale score of 3. His imaging now showed new intraventricular hemorrhage, new subarachnoid hemorrhage in the left cerebropontine angle. So it's quite localized and at the level of the foramen magnum. And he now had a ruptured aneurysm that was 3.4 by 2.9 millimeters. Day 10, there was no change in his imaging, but on day 12, brainstem death was confirmed, and he was declared dead. I can't remember, actually. He may have had organ transplant donation after that, but not the head. So here is the some imaging. The pica is the largest and most distal branch of the vertebral artery. Most of the time, the pica originates above the foramen magnum. 4% of cases it is identified at the level of the foramen magnum, and 18% it's below. It's actually in the neck. So here we have some nice imaging, and you can see the aneurysm here, showing the 3.9 by appearing. Oops. And you can see it over here. So we can see on imaging he's got an aneurysm of some variety. So this case is nice for me because we've got all that imaging before we do my post-mortem. We fixed the brain. I think I did it myself. So there's diffuse edema with tonsillar grooving, congestion of vessels and subarachnoid hemorrhage confirmed. No contusional damage was identified, and there was no focal lesions on sectioning of the brain. That's gross sectioning, I should say. But there was a rather disrupted corpus callosum, but whether that was us or not, we would have to see. Because, of course, corpus callosum is a classic place to get hemorrhage from in diffuse axonal injury, diffuse traumatic axonal injury. In fact, on histology, he has bleeding in the corpus callosum. And you can see he's got some damage, and there's some macrophages appearing. And there are axon bodies, some balls. And your beta-APP, so that is really one of the main immunohistochemistry stains we use, is positive. And this is illustrative that probably some of the concussive cases we have and people who survive probably do have some axonal, have some true axonal injury. It's just that they recover from it without obvious deficit. And here is his basal vessels, and here is the aneurysm. And you can see it's quite small. I dissected it off. And so I was thinking, how am I going to handle this? And the answer is, of course, I just embedded it all. I just put the whole thing in. But there you are. There are some close-up pictures of it. So I put it in, and then I went to my techs and kindly asked them to keep doing levels. And I'd sort of do 10 at a time and then go back. And in the end, we did 33 levels on this with various stains. So that's the pentachrome. That's just your H&E. And as you sort of go down, you begin to get nearer to the neck. And this was a not a Movat, Masson trichrome. I'm lucky in that I've got a full histopathology laboratory for surgical pathology. And now you can see the site where the vessel is and the start of the aneurysm, and you can see it's a false aneurysm. So there's been disruption of the vessel wall with a small laceration. And here we just have close-ups of the H&E and the pentachrome, basically showing disruption of the wall and the presence of blood clot. And here you can see that there is a bit of the rest of the external part of the vessel still present, and then it disappears, and all you're left with is blood clot. The other vessels were normal. So what's happened is obviously that has grown over the days as a false aneurysm, and then eventually it's ruptured. And I'm not sure they could have done anything for him, but you know, certainly when it was a millimeter, and he was otherwise asymptomatic, and it's obviously a very difficult area to do neurosurgery on. So this was really the only case when we reported the literature where we had serial imaging to show the ruptured aneurysm. So, you know, the bottom line is it's a difficult area to examine, and we need to think before we examine it how we're going to do it. And it is worth just doing a little bit more. My lab were very nice. So they were quite interested, and I just kept going back and showing them and said we just need a bit more levels. And so there's chapters in our book on, I'm not trying to sell it, you try and get an electronic copy of forensic neuropathology. Helen Whitwell had written the first edition. Sadly, Helen died last year, but Daniel and I are intending to start on the third edition soon to update it and put a couple of new chapters in if you've, but there's also, you know, you may not have, you know, the book's not cheap, but they're usually, often the universities get access to the electronic version. My university does. So that's a quick run through of vertebral artery trauma. As I say, we will update it. The real experts on the vertebral artery are Daniel and Paul Johnson, who write the chapter in the book on it. But I've seen a few cases over the years. And with that, I'll take any questions. Otherwise, thank you for your attention. Paul Johnson's got some very elegant real-time, you know, video of injecting the dyes in and showing it coming out. He's worked on it because his old boss used to, Jim Burns, wrote some papers back on the vertebral artery showing age changes, because there are also age changes in the vertebral artery. One of the interesting things actually about a lot of the human body is it's surprising how little we have studied normality and age changes in parts of it. You know, I've been looking at the pancreas. Well, no, I've been thinking about looking at the pancreas, and there's very little post-mortem examination of the pancreas because it autolyses. But there's a great interest in the pancreas now for type 2 diabetes and the like. There are some radiological changes, but no one's done any comparative morphology on it because we don't look at the pancreas at post-mortem because it's autolyzed. And same applied to the vertebral artery, you know, looking at age changes. Most of the people who die of traumatic vertebral artery rupture are young males. They tend not to be older people because they're the people that get in fights in bars. Okay, well, thank you very much indeed. It's been a pleasure to deliver these lectures. Thank you.